So again, I would like to thank you all. Now, since we are discussing about nightmares, I think diabetic vitrectomy is one of the most challenging cases, and sometimes you can have a very severe uncontrolled bleeding, which can just hamper your whole surgery. So in diabetes, two things have to be avoided. One is creation of breaks, and the other is to prevent an uncontrolled bleeding. Bleeding, of course, will happen in a diabetic vitrectomy, which is unavoidable. So I always instruct when I was a teacher, now I'm into private practice, that whenever there is a bleeding, I ask my fellows, you should stop everything. You should stop the bleeding first, and then you should proceed with the surgery. Because if there is immense bleeding, then you can't complete your surgery. So it's like a war. So with the advancement in the instruments which we just spoke about, the visualization and the 25 gauge and 27 gauge, the incidence of bleeding has really come down and the outcomes have really improved a lot. But still, there is a very high probability of having a very severe bleeding in diabetic patients, especially in our country. They have got very uncontrolled diabetes. They come in end stage diabetes with very severe aggressive fibrovascular proliferation. And despite giving anti-VEGFs before surgery, we can face situations in which there is a very severe bleeding. So what to do? I'll just go by a step-by-step approach. So this is a patient in which I gave a preoperative anti-VEGF. I do now most of my surgeries with a cutter only, most of the dissection, sometimes use a bimanual approach. So there are mild bleeders here. If there are mild bleeders, there's nothing to worry. You can just increase the bottle height as discussed. And it's very important to monitor the IOP and reduce the bottle height once you are convinced that the bleeder has stopped. You can laser or cauterize these small bleeders as just shown. And relatively, this is a simple, straightforward case. Once you've relieved all the traction and you are successfully managed not to create a break, you just have to do a panatal photocoagulation, and a no intraocular tamponade is also needed. So this is like a mild bleeder if there is. So as I said, if there is a mild bleeding, you can just cauterize the bleeder. A bimanual approach sometimes helps, in which you can just aspirate the blood, and with the other hand you can dithermize or photocoagulate the blade. Another point is sometimes try to cut the hyaloid from outside in approach. First cut the 360 degrees, then come closer to the disc, because if there is a major vessel near the disc or a fibrovascular proliferation, if you just burst it, there can be a very severe hemorrhage. So you have to be very careful. So I always prefer outside in approach, but in sometimes when there is a thick proliferation at the posterior pole, you have to start at the center. So as I said, the next step is, if the bleeding is not controlled, raise the IOP. It's very important to monitor the time, because usually the disc perfusion is usually compromised in diabetic patients. So you have to lower the IOP again and recheck whether the bleeders are closed or not, because sometimes what happens, we continue the surgery with a high IOP, and once we are closing the case and we reduce the IOP, the bleeding tends to come up again. So it's important to lower the IOP and check the bleeders. So what is the next thing to do? So this is a video I just showed. I did an outside in approach. So I'll clear all the vitreous from outside. Now there is a thick proliferation which is involving the disc. So just showing outside an approach. So once I've removed all the peripheral thing, now I'm doing the dissection with the help of a cutter only, involving the central frond. So all these bridging tractions are being removed. You can remove, these fine fibrovascular fronds, after removing all the tractions, can be, it's not necessary to remove all of these membranes. If they're not causing any traction, you can leave these rather than trying to remove these and create a break. So we have to prevent the formation of a break also, because then you will need some extra tamponading agent, which will probably even hamper the final visual results. So you can see most of my dissection, I think now everybody does mostly with these fine cutters which are available, and a bimanual surgery really helps in these. After that, you can just cauterize the bleeders. So I'll just go to the next case. So what happens if still there is a persistent bleeding? The next step would be, you should plug all your ports, and it is always better to use valve cannulas. Raise the bottle height and wait for some time. With the pressure, sometimes these bleeders stop, and you can proceed with the surgery after 2 to 5 minutes. However, still if the bleeding is continuing, what to do? So PFCL is a very important tool which I use nowadays if there is a persistent bleeder at the posterior pole. So the important thing is here that you have to not create any break, because if you created a break in the area of the traction and you are inserting PFCL, there are chances that it might go into the subretinal space. So in this case, there was a frond which is present just superior to the macula, but there was a persistent bleed also underneath the frond. So what I did, I injected PFCL. Once PFCL tamponaded the blade, it helped me to remove the membrane under PFCL. So PFCL not only stops the bleeders, it also acts as a third hand to support the retina and prevent the break. So very gently you have to do a tangential traction, because removing these membranes which are very adherent, with the ILM forces, especially if you're not dissecting, it can create a break. But in this case, it was successfully managed. So if there is a clot which is formed, a small clot is formed, you should not try to remove it, because there might be a secondary bleeding, and these secondary bleeders are really much worse than the primary one. So let the clot stay there, and you can try to do an endolaser under PFCL, which is much more good, because the PFCL presses the retina against the RPE. So this is a video in which something you should not do. So there is a clot which is present. I have completed my surgery. I have done a PRP. There is a blood clot which was present under the PFCL bubble. So as the video progresses, you'll see that I'll be very successfully able to remove this clot, and at that moment I was quite happy. But at the end of the surgery, when I did a air-fluid exchange again, the bleeding started again, and the clot was slightly much more worse over the macula. However, I did not then do anything, because I knew that since I've not created a break, this small clot over the macula will resolve over some time. So the patient may have some delay in his recovery, but probably I will not have to operate again. So I've removed this clot under PFCL. And I think that I just thought that I've done a very great job. And you see, at the end of the surgery, there is again this clot which is formed over the disc. So if there are small clot which are not over the macula and they're not bleeding, it's always better to leave it. So in this case, I gave a tamponading C3F8 agent to tamponade the bleeder to prevent further bleeding. So another case, just a diabetic case in which to show the role of PFCL, this was the tabletop tractional retinal detachment. After removing the vitreous, whole of the central macula is detached. It's a chronic old detachment. So I just injected a PFCL bubble again, because there was a persistent bleeding from the underneath the fibrovascular front, and then gently just doing a membrane dissection and segmentation with a forceps and a cutter only. A bimanual approach would have been really good in this, but I managed to do it without a bimanual technique. So gently removing whole of this traction, the central retina, although detached, there is no break. So again no tamponading agent needed. You can just leave air inside the eye. So I'm just lasering the peripheral detached retina, and the central detached retina, I'll just leave it as it is. So as such, there is no active bleeding and no breaks. So just a laser at the attached retina, and probably laser augmentation once this chronic TRD settles. So this is another case in which there was a persistent bleeder at one of the fronts. So this is a one-eyed patient. This is his only eye, and he had a thick proliferation at the periphery. I've done all the peripheral dissection. Now again, there is a bleeding which is coming from underneath the fibrovascular membrane, which is quite close to the macula. So in this case, I used a scissors to do the dissection. I injected a small PFCL bubble to tamponade the bleeder. I kept on tilting the eye to proceed with my dissection, and then again tilted to tamponade the blade. So continuous slide movement, and just my aim here was to give him a good vision. Just so this was his only eye, a vision in which he can just maintain his whole life without being dependent on anyone. So my aim was not to remove all the membranes. So I did a dissection, removed all the traction, and he was a young diabetic patient, lost one eye because of severe diabetes. So I've just relieved all the traction, and you can see with the help of scissors here, the bleeding was controlled with PFCL only, and laser had been done before. So you can see some fronds of fibrovascular fronds are there. I didn't want to be very aggressive in this patient. The patient gained a vision of about 6/12 in this patient, and he was very happy. And this is the picture at 1 month. So you can sometimes leave these few fibrovascular proliferations which are not causing any traction, not need to be very aggressive. We have to give a functional outcome, and we don't have to have a good fundus photo. That should not be our aim. So still, if the bleeder is not localized, in very worst scenarios, if you have not created a break, what I do is I sometimes leave PFCL inside the eye and reoperate the patient. The most important thing is to not create a break, like in some GRT cases. So I have done it in few cases, just left PFCL, it tamponades, take care of the bleeds, and then probably after 5 days, you can go easily, and the bleeding usually stops, and you can give an anti-VEGF at the end of the surgery. So these are another techniques which I said. Sometimes when I just go at the posterior pole, I just create a small opening, a plane between the posterior hyaloid and the retina. So here what I'll do, I'll use PFCL as an agent to do a membrane dissection. So I'll just inject PFCL between the plane. In these two videos you can see. So PFCL, it just seeps between the plane of the retina and the fibrovascular proliferation and the taut posterior hyaloid, and it just dissects it. So it not only helps in the separation, it also prevents bleeding and prevents the formation of breaks, and also reduces the surgical time. So, but for this you have to have a proper plane, you have to define a proper plane, and then you can just proceed with the normal dissection with the help of a cutter at all the edges, all the areas of the attachment. So, slightly you can become slightly more meticulous, and since there is not a recurrent hemorrhage which is happening because of the such a dense proliferation, I can just go proceed with my surgery and my dissection easily. Had there been a very severe hemorrhage, most of my time would have been spent stopping the bleed rather than proceeding with the surgery. So both of these cases, they went out quite fine, luckily, with the help of PFCL dissection. But you can't use this in every case, especially when the membrane is very tightly adherent, or you probably don't need it in much simpler cases in which the attachment is not very extensive. So as I'm doing the dissection, you can see that the PFCL will just continue to move and seep and also protect the further the retina and also prevent the bleeding in the first video. So these videos are around 2 minutes videos, so I think I have some time. So and again you can do the laser under PFCL only. That also sometimes gives some time. If there is a bleeder, the PFCL will remain there. It will press the vessel and it can further lead to the formation of a clot. So not only you get time, you can do you can complete your laser completely. Sometimes I even augment it with ARC, that is the anterior retinal cryopexy, at the edges and at the area of the ports, because you can have neovascularization at the area of the ports in diabetic patients, which can lead to post-op, maybe in a later stage, at a delayed hemorrhage. So you can see most of the cases, most of the dissection was done quite cleanly. In the second video, removal of these residual blood clots and membranes, and in both these cases, fortunately no breaks. So again, you don't need a tamponading agent like a silicone oil or intraocular gas. So I think this is most important. You should have a pre-operative workup. The blood pressure should be under control. Diabetes should be under control. It is better to stop the use of antiplatelets and anticoagulants, especially in these cases, because there are a high chances of intraoperative and postoperative bleed. So there are few studies which support it, although long-term outcome may not be affected, but the surgery probably becomes easier. And anti-VEGF, as I mentioned, pre-operative use of anti-VEGF has really reduced the incidence of bleeding. We should operate within 3 to 5, I think is late now. I think we should operate within 2 to 3 days after giving. It has really improved, reduced the bleeding and improved the surgical success rate. But we should keep in mind, once we are giving anti-VEGF agents, it can also worsen the tracheal retinal detachment. So be ready to operate at an earlier stage. So just to conclude in putting everything in together, I think technique is very important. It is very important to use valve cannulas nowadays. Chandelier system bimanual is a very good technique, especially if you are in the learning stage. And it always, I try to cut the hyaloid from outside in approach, but however, if there is a dense proliferation, as I showed in the last video, I can start at the center by creating a plane. So you can use in a bimanual approach, you can also aspirate and coagulate with the diathermy or a laser at the same time. Intravitreal anti-VEGF agents before the surgery really help to prevent intraoperative bleeding. You should never pull a fibrovascular proliferation which is present at the disc. It can lead to a severe hemorrhage, which is very difficult to manage, and it will compromise the whole of the surgery. And the use of PFCL I have highlighted. It really tamponades the retina, prevents bleeders. You can do a laser under it, and in worst cases, you can even leave PFCL inside the eye, and you can reoperate the patient after about 5 days. So thank you everyone for listening. Thank you.
You're the chair, but I'm going to take on your role. Can you tell us a little bit about leaving the heavy liquid in the eye?
Yeah.
And why you wait 5 days?
So the main role of leaving the heavy liquid inside the eye is that there is a very severe persistent bleed which I am not able to control. I'm not able to control means I can't go ahead with my surgery, so I have to abandon my surgery. So in those cases, I'll put PFCL so that the heavy liquid, and ask the patient to stay supine, it presses the bleeders and stops the bleeding, and it has really worked like magic in 2 to 3 cases. The important thing which we have to consider here is, in some cases, you can get a very severe post-operative inflammation with PFCL. So I think that should also not bother you. You can start oral steroids, and anyways, after 3 days, you're going to operate the patient again. So it can lead to inflammation, but I don't think something which should really bother you. Start the patient on topical as well as oral steroids, and be ready to take up the patient after about 3 days. Most of the times, in fact, all of the times I've used it, the bleeding usually stops. I'm not seeing the bleeders coming out again.
So the 5 days, I also do like you do. The 5 days is good because the clot will have liquefied. And the other advantage is not only it stops the bleeding, but the blood itself moves to the front part of the eye so you can actually skim it off. But as you've highlighted, there's lots of inflammatory mediators and sometimes staining of the lens, but it usually will settle.
So, taking that forward, Bhuvan, if you, when you inject the PFCL and there's a massive bleed happening, would you first do a fluid air exchange and then put in PFCL,
see, there are
or
other
would you
methods.
give a PFCL immediately and then leave it like that?
So as I said, we can go by a step-by-step approach. We can even mechanically press the bleeder if you are able to localize it. So the main thing is the localization of the bleeder. If I'm able to see the bleeder and I can close it, then that's not a problem. The problem is when I'm not able to locate the bleeding point because of the hemorrhage coming again and again. Doing a air fluid exchange can work in some of these cases, but what now I prefer is to start with PFCL, because if air can work, then PFCL will 100% work better. So the main aim is to find the bleeder. If I'm not able to close the bleeder, and the moment I remove my PFCL, the bleeding again starts. So it will same happen with air also.
Have you cauterized under PFCL? Just a question.
I think I may have. I can't just pinpoint, but I think I may have.
You can cauterize
Yeah, you
under
can.
PFCL. Shijen, you want to?
Yeah, I think if you cauterize in the PFC, sometimes just some small bubble, but it's okay.
Yeah,
It's
you
very,
can.
very limited. Yeah.
PFCL does not stop the bleeding. It shifts the bleeding to the periphery. What happens is that the bleeding stops because you raise the pressure on it.
No.
Because you're not going to do just one, you're going to do both the things together. The PFCL helps because as you said, the blood comes up. So it not only comes up, goes to the sides of that PFCL also. So you have to be careful because it will form a secondary membrane at that level. It depends on where you've got the bleeding from. The basic problems come when the bleeding is at the disc. If the bleeding is in the periphery and the fraction has been relieved from that area, it's no-brainer. You will do the diathermy there. The problem comes when it's somewhere in the periphery and the traction has not yet been relieved. That's the time when probably the best way would be to shift to a bimanual approach and under a little higher pressure, maybe 40, 50, remove that traction area, clear that, and then diathermize it. If it's on the disc, that option is not available to you. You would have to take the pressure to maybe 60, sometimes even 80. See the point which is the bleeding point, and sometimes it will stop. You can actually combine this with mechanical support to the same area. So if you have a pressure of 80 and you add mechanical support, and normally what I'll do is I'll close the silicon tipped flute needle. I'll close it and then press it on that area. You see, that's soft enough that it will not create too much pressure there, but it's enough pressure to keep the vessel closed. And if you do that for a minute and then you take it off and then you bring the pressure down, if it stopped, great. But sometimes I've had a situation at least twice when that did not work. Now when that happens, the one time when the next step was, I had PFCL there, I had a pressure of 80, I cleaned up the blood from the periphery, and then I did a fluid air exchange at a pressure of 60. And after doing that, I put silicone oil, not PFCL. The reason for silicone oil was, I get a clear media and the blood will settle under the silicone oil. And then, as you said, it will liquefy over the next few days. And 3 weeks later, I went in, I had liquefied blood which I could remove. In fact, part of it I removed under silicone oil. Whatever was left, then I removed the silicone oil, removed that. the bleeding had stopped, and I could complete the surgery.
So with all due respect, I agree and disagree with you also. So I fully agree for a peripheral bleeding, what you said was right. But so PFCL, it really stops the bleeding, which I have seen in my experience. There is no need to raise the bottle height once PFCL is inside your eye. It will do the same thing by pressure tamponading the bleeders. And in many of time, as I said, you can leave the PFCL for a longer time, do your PRP. In those 10-15 minutes, once you remove the PFCL, in 70 to 80% of the times, the bleeding usually stops. So at the disc, sir, at the disc also, it will stop. It will stop till the PFCL at least is there. So probably those are the cases in which you can leave
So
PFCL
Dinesh,
also.
how it works is PFCL has a specific gravity of say about 1.8 to 1.9 depending on what you use,
And
and on top of that you increasing the infusion pressure. So it's a double.
no, no,
Yeah.
sir.
So
Sir, the
the
PFCL will
weight
work very
plus
well,
the
even without increasing the IOP. And so, secondly, I would, at my best, I would try to avoid silicone oil in a diabetic patient. If the only condition in which I'll use silicone oil is I've not lasered all my brakes. Otherwise, I will 100% try to avoid silicone oil, because if there is a bleed with silicone oil, then the patient is going to have a pressure of more than 40, 50 the next day, 100%. No, no, sir.
You've stopped the bleed. Your bleed is now localized under the silicone oil. If the pressure goes up to even 40, you have enough drugs to control your pressure for that temporary period. The important thing is you've got loculated blood, you don't have any membranes forming anteriorly, and anterior membranes are more of a problem than posterior membrane once everything has settled. And as you said, you've lasered. Your laser is complete, only there's some area there's blood. You waited for the retina to settle down and lasered it, and now you're taking out the silicone oil and the blood. So that's the safest option for you. PFCL, on the other hand, does not work in terms of bringing down the bleed. That is a misconception. Only very small bleeds can stop with PFCL.
Okay, okay. Thank you, sir. Thank you for